Hello friends, now I will be talking to you about ITP, that is Idiopathic Thrombocytopenic Purpura. It is an autoimmune disorder, and the special thing about this that it only has antibodies against the platelet. That's why there is isolated thrombocytopenia. P stands for platelet. So there is low count of platelet, only isolated. That means there will not be any problem with the hemoglobin or any problem with the TLC count, or RBC count or platelet count. RBC and WBC count will be normal. Now what happened? There are autoantibodies, IgE antibodies against the GP2B3A receptors. Now let's learn the basic concept about the pathophysiology, what happened in these patients. So in the pathophysiology, first of all we'll see what happened in a normal platelet. This is one platelet, P platelet. We have another P platelet. And we have GP2B3A receptor, GP2B3 receptor here also. So when normally the platelet aggregation occurs, the fibrin get attached, fibrin. So it is a fibrin which stabilizes the platelet plug, and remember this is getting attached at GP2B3A receptor. This is what happened in a normal platelet plug formation. Now in these patients we have antibodies against GP2B3A receptor, and these antibodies they get and bind to these receptors. Now the platelet to which antibodies are attached, they are engulfed by the macrophages, and these are taken to spleen where they are destroyed. That means it's a type of extravascular destruction is there. So if we look at the pathophysiology again, first of all antibodies are involved, macrophages are involved, and the spleen is involved. What is the applied part of this? So when we will be using treatment, we use intravenous immunoglobulin. What this immunoglobulin will do? It will not let macrophage engulf the platelet. Okay, so as platelet are not taken up by the macrophages, the platelet will not be destroyed. That's why we use this in the treatment, which I'll talk a little later on. Now in the very advanced cases, splenectomy is done. Why? Ultimate site of destruction of these cells are in the spleen. Okay, so now you know in the treatment later on we'll be using intravenous immunoglobulin and splenectomy, what and why, but we have understood the basic fundamental. Now let's see what are the causes of ITP. It may be idiopathic, and this is usually in children. In secondary causes are there, but they are more in adults. So autoimmune destruction of platelet, SLE is the most common secondary cause. It may occur in HIV, CLL and lymphoma are some of the other causes of autoimmune destruction of platelets. What are clinical features we have? in the mild cases, we had just epistaxis, purpura or oral bleed. But in severe cases, patient may have GI bleed, or patient may have dysfunctional uterine bleeding, DUB, severe bleeding in the per vagina may be a feature. Now, in children, what I told you is usually idiopathic. It is usually of abrupt onset, usually 2 to 3 weeks after viral fever, and platelet count may go as down as below 20,000, but spontaneous remission can occur in around 80% of the cases in children. As far as adults are concerned, they are usually insidious in onset. Note, they were abrupt in children. There is no viral fever before this problem, but here we have a viral fever 2 to 3 weeks before. The count is usually around 20 to 80%, and spontaneous remission is usually not a feature. Just remember, here it is in around 80% cases spontaneous remission occurs. So now we investigate, but before that, remember, spleen and lymph node are not enlarged. Okay, so investigation. Best initial test is CBC and peripheral blood film. As I told you, RBC count will be normal, WBC count will be normal, but there will be isolated thrombocytopenia, and we see giant platelet are seen. Giant platelet are seen, HB and TLC or are normal. If we do the bone marrow examination, increased megakaryocytes are seen. Ultrasound is done, and what we find, spleen size is normal, splenomegaly is not a feature. Antibodies to GP2B3A receptor, this is the most sensitive test, but it's not a very specific test. So you can say the most accurate test is to look for the antibodies to GP2B3A receptors. Now let's talk the treatment part. If the count is above 50,000 per ml, platelet count, and there is no bleeding, then these patients do not need any treatment. But if the platelet count is 20 to 50,000 and or mild bleeding is there, you have to give prednisolone. It is the best initial treatment. If the count is below 20,000 and or there is severe bleeding, then we have to give intravenous immunoglobulin. And how it is going to act, this I have already discussed with you. It is the fastest acting drug, but it is given only in Rh positive cases. It is never given in Rh negative cases. Now, despite all these things, patient still has recurrence problem. Then in those cases only, recurrence cases, then we go for splenectomy. But remember, it is never done, splenectomy is never the initial choice, because splenectomy itself has created a lot of problem. These patients are prone to sepsis. That's why before you do splenectomy, patients should be given Haemophilus, pneumococcus and Neisseria meningitidis vaccine must be given. And Still after splenectomy also problem is there, then you can go for thrombopoietin agonist. They include romiplostin, which are given subcutaneous, or L-trombopag, which are given orally. And the new drug rituximab has come. It is a anti-CD20 drug. This can also be given in some of the cases. This is all about ITP. Thank you very much.